This is a meta-analysis of all these trials. Almost similar study has been similar results. FFR versus angiography-guided non-culprit lesion PCI, because we have seen that FFR was used in compare acute and dynamic-free primality, whereas culprit and PRAMI was driven by angiography-guided revascularization. However, the meta-analysis showed that there was no significant difference when revascularization was done either by angiography-guided visual estimation or by FFR. There was no evidence of any heterogeneity. Same was seen in terms of same sitting or index procedure revascularization or a staged approach. That is whether the non-infarct artery was opened in the same sitting, depending on the operator's experience and expertise, or whether it was staged procedure. The result was similar. So the clinical caveats, one important thing to keep in mind is that in prospective study, we know that in natural history of atherosclerosis, nearly 50% of the events, future cardiovascular events, it occurred in the non-culprit bystander lesion. So in no way they can be considered as a, benign lesion. And interestingly, most of the culprit lesions who are responsible for the future events, they are usually angiographically mild at baseline, or the vulnerable plaques can be mild. An important subset, those were not included in these trials, were the subsets of cardiogenic shock, which was tried, because these do not apply to patients in cardiogenic shock, which was tried or tested in culprit shock trial. Culprit lesion versus PCI versus the multivessel PCI and cardiogenic shock, which showed, however, entirely the opposite result, that showed increased mortality of the patients who underwent multivessel PCI compared with culprit vessel only PCI in acute MI with cardiogenic shock in both short-term as well as in long-term basis. So in patients with acute MI, whether STEMI or non-STEMI, in culprit shock, both even non-STEMI patients or NSTMI patients were also included with cardiogenic shock, and significant reduction in the primary composite of all-cause death and severe renal failure requiring renal replacement therapy was observed in culprit lesion-only strategy rather than with complete revascularization during an index event, with an very significant 8.2% absolute reduction in mortality within next 30 days. So in a nutshell, we can understand that MI with shock is possibly an entirely different ballgame, and various other factors like operator's expertise, dye usage, patient's hemodynamic status, renal function comes into play. So depending upon all these trials in 2017 ESC guidelines, they upgraded this complete revascularization indication from class 3, that is harm, to straight away class 2A, that is may be beneficial or likely to be beneficial in MI patients, mainly based on these 4 trials, that is PRAMI, dynamic 3, culprit, and compare acute, which has been further substantiated and consolidated based on the, this complete trial. Thank you very much.